coronary heart disease. Okay, so what do we expect you guys to remember and learn today is to understand what are the pathophysiology of atherosclerosis. I want you to know what are the definition of ACS, how to differentiate between stable, unstable angina, and also STEMI and non-STEMI. And I expect you guys to be familiar after this lecture to be familiar with how to differentiate them, how to diagnose, and how to manage acute coronary syndrome. And lastly, do have a bit of exposure on how to interpret ECG in the setting of heart attack. Okay.
Sorry, doctor. Just now can see your slide, but then now cannot see your slide.
See,
Okay. Now can see.
Oh, when I do slideshow cannot. How about this?
Slideshow cannot.
Oh, okay. Let me change the setting.
Okay.
Maybe stop presenting. Maybe allow to share screen. Yeah. How about now? Can?
Yes, doctor. Can see already.
Yeah. Okay. Yeah, so the bold one is the one that very important for you to remember now. High chance will come out in exam. Okay. So I think I have talked to you about the anatomy of the heart during the last lecture. It's something that you need to remember by heart. So our heart basically is situated slightly on the left, is in the middle of the mediastinum. And the heart structure, we have 4 chambers. So we have atrium, left ventricle, right atrium, and right ventricle. Okay. And in between the left atrium and left ventricle will be your mitral valve, and between your right atrium and right ventricle will be your tricuspid valve. Okay, so and between your aorta, this is your ascending aorta, and this is your left ventricle. In between that will be your aortic valve. Okay, so our main job of the heart is mainly to pump the blood from the left side, left ventricle to rest of the body, while the right side of the heart pump the blood through the pulmonary artery to the lung is for oxygenation of the blood, and then we'll come back to left side and pump blood to other parts of the organ of the body. Okay, and heart is a muscle, so it does require oxygen or blood supply to help supply the muscle with nutrients and oxygen to function as well. And it does so by 3 major vessels. So mainly we have 3 coronary vessels. You do not need to remember the name of it, but you just roughly remember that you have 3 vessels. That's why sometimes when you go through patient history, some people, they would tell them you have single vessel disease, dual vessel disease, or triple vessel disease. This is what they are talking about. Okay, so we have 3 major coronary vessels. The right side is a right coronary artery from the right coronary cups, and we have left coronary. Left coronary artery will divide into circumflex. Circumflex means it's circumferential, so you go to the back and like wrapping around the heart. Another one is called left anterior descending artery. So if you look back the heart structure, so on the, you can see my cursor, right? So this area is your left side of the heart. This is the left ventricle. So our heart, mainly the left side, does most of the work. That's why the left side of the ventricle is thicker, has more muscle, because it need to pump the blood through entire body. And mainly it's actually supplied by your anterior descending artery. That's why your anterior descending is a very important vessels for the heart. If it's clogged here, then you have problem, you have major heart attack. Okay. So while right side of the right coronary artery mainly is supplied right side of the heart. So if there is a complete occlusion on the right side, patient does not present so ill compared to the left. Okay. So when there is a problem with the coronary vessels, there's a blockage. That's what we call, and reduce the blood supply to the heart. That's what we call ischemic heart disease now. So how does it happen? Mainly, this lecture we are talking about ischemic heart disease due to atherosclerosis. due to the prolonged or chronic plaque formation inside the vessels. This is just a cross-sectional image of our vessels. I think you guys should be seeing these slides or this type of illustration quite sometimes or many times before. So this is a cross section of the vessels. You have three layers. The innermost is called intima layer, and the red color is representing blood. So the narrowing or atherosclerosis formation happen because of a few risk factor. So just think of it like your clog drain. Okay, why your drain will clog? Number one is because it can happen because of viscosity of the blood is very thick. Okay, if your blood is very thick for various reason, it can increase your chances to have a clot formation in the vessel itself. For example, if you are a heavy smoker, it can increase the risk of erythrocytosis or thickening of your blood. Okay, if you're congenital, your heart, your blood is very thick, it can increase the risk of thrombosis or blood clot as well. Number two risk factor is endothelial injury. So how does endothelial injury can happen? Commonly in ischemic heart disease patient, there will be dyslipidemia, high blood pressure. All these increased chances of having minor endothelial injury. So and it does not happen in single day. It happens over the years. So if you're uncontrolled hypertension, you start to have a little bit of cholesterol deficit because of your high cholesterol. Then you have a high blood pressure. You have a minor tear in the intima. You can have minor clotting developing in the endothelial layer, and when that getting worse, it can cause narrowing of the vessels. And if the chronic plaque suddenly ruptured, it can cause a total occlusion of the coronary vessels, and that lead to myocardial infarction. Okay, so of course there are other various risk factor can lead to this. Commonly, highest risk is smoking, high bad cholesterol, high LDL, low LDL, low HDL, diabetes, and of course genetic inheritance risk factors. If your parents has ischemic heart disease, the chances that you also will have it if let's say you have other uncontrolled risk factors. So this is just summarized. Do not need to remember all those fancy terms that you do not understand. So mainly remember, smoking is the highest risk factor, uncontrolled hypertension, high cholesterol, and then flow factors means that you have very thick blood due to smoking or due to erythrocytosis. Okay, this one is important. The causes of atherosclerosis. So whenever I say important, you need to jot down. So in case it's it will be highlighted during exam. Okay, so the plaque can actually be a stable or unstable one. So with the chronic formation of plaque, a lot of time that will just remodel itself to improve the blood flow to the heart. But if the plaque suddenly ruptured, it become unstable, that can cause a sudden occlusion of the coronary vessel and lead to heart attack. Okay, and that will cause acute coronary syndrome. So this is a very important slide as well. ACS can basically divide into three subgroups. Okay, it can be unstable angina, non-STEMI or non-ST elevation myocardial infarction, or ST elevation myocardial infarction. Okay, just remember this thing. You have three things. If let's say patient has heart attack, it can be unstable angina, STEMI or non-STEMI. Okay, then we're going to talk about each of them. Okay, I think we'll come back to this slide again. I'll come back to this one. Okay, so what do we mean by unstable angina and STEMI and non-STEMI? So in unstable angina, this is a cross section of our blood vessel. Just imagine your blood vessel is a cylindrical shape, and we cut it into half. So this is the lumen, and this is the existing clot and blood flowing like this. So if you have a plug rupture, it can you can have a sudden reduced blood flow to the myocardial muscles, but then it does not occlude totally of the vessels. Means you still have blood flow. You just have relative reduce in the blood flow and oxygen supply. That's why the term unstable angina. There is ischemia, but then there is no muscle death or muscle injury because there is still perfusion. Okay, so in this case, you do not have, this is a cross-sectional image of the heart muscles. So in this unstable angina, you will not have muscle injury because there's still oxygen and blood perfusion. But ECG will still show changes because of the strain. You can see ST depression in the ECG. Okay, I will talk about the ECG in the next few slides. So what about STEMI and non-STEMI? But in contrast to the unstable angina, in STEMI, the thrombus or the plaque suddenly ruptured and it caused total occlusion of the coronary vessels. Means there's no blood flow to go and supply the area of the muscles, and you have a zone of necrosis. Necrosis means a programmed cell death, means the muscle die. And once the muscle die, it will not grow back, it will not become alive again. So you have a you have a permanent injury to the heart muscles. So this is a post-mortem photo of your heart. This is the left ventricle. You can see the red color is viable muscles, and the white color is the ischemia or fibrotic area, and the black is the necrotic area. So there will be a permanent cell death or muscle death due to complete occlusion of the coronary vessel. This is STEMI. So when complete occlusion or causing STEMI, like the name suggests, is ST elevation. So in the ECG, you will see ST segment elevation. Okay. And how about non-STEMI? Non-STEMI means it's a non-ST elevation. Okay. When in non-ST elevation, there's also a thrombus or plaque rupture. There's a significant ischemia causing a reduced perfusion to the heart, and there's a muscle injury. So you can see there's injury to the wall muscle, but there is no necrosis, there's no cell death. Okay, that's how you differentiate between them. So if let's say unstable angina, you just have pain because there's inadequate perfusion, there's no injury, there's no cell death. So your cardiac biomarkers should not be increased. Cardiac markers is something we use to diagnose or to identify muscle injury. Okay, when there is a muscle injury, the muscle cell will lyse and they will release some chemicals, and those are the markers that we use to identify this. In our body, there's different muscles, correct? No? So most of it, the muscles are skeletal muscles like your quadricep, or your bicep, your triceps, your hamstring. Those are skeletal muscles. When that injured, for example, if you go for a long run, your muscle injury got cramps, they will release chemicals, and commonly is called creatine kinase or myoglobin. So that type of biomarkers is not specific to the heart. But nowadays, we have something more specific. Some biomarker is very specific to the myocardial muscles. Means it's only cardiac muscles biomarker only. That's what we call troponin. Troponin is very specific for heart muscle injury. Okay. So you will only have elevated biomarker or troponin when there is STEMI or non-STEMI, because muscle injury only happen in these two. All right. So how do we differentiate all three of them? Of course, clinical history is important, but history, you cannot differentiate these three types of ACS. Mainly, we need the ECG, and also we need the troponin. So if there is a ST elevation in the ECG with chest pain, it's called STEMI. If let's say patient has typical chest pain, there is elevated troponin, it's non-STEMI. As elevated troponin, chest pain, but if let's say no elevated troponin, it will be unstable angina. Okay, everyone clear about this concept?
Yes.
Yes, doctor.
Yeah, this one very important. Okay, very important. It's the same thing. Okay, so remember ST elevation, non-ST elevation, and unstable angina. Okay, it's sort of repetitive regarding this chest pain, but this concept we need to understand as well. So, what means by angina pectoris? It actually comes from a Greek word. Angina means it's strangling pain, while pectoris means chest in a Greek word. That means that it's a strangling pain at the chest. So it just definition. The definition just means that it's a pain causing syndrome due to induction due to the reduce in the oxygen supply, or there's an increase in demand of oxygen of the myocardium. So typical type of angina chest pain, it will be provoked by emotion, provoked by exertion like climbing upstairs, or emotional or psychological stress as well. And it can be improved with GTN, nitroglycerin, the medication that people put under the tongue. Okay, and the typical pain that people will describe will be heaviness, and it can relate to the left side of the arm and the jaw. Of course, as I mentioned in previous lecture, diabetic patient can have atypical pain, including epigastric pain. Some of them may can have just a fullness or indigestion type of pain in the epigastrium. So you need to have a high index of suspicion whenever patient complain of central chest or abdominal discomfort. Okay, so what causes the angina? You can have pain when you have increased myocardial oxygen demand. If you're going for exercise or you have hypertrophy, when you go for exercise, your heart will beat faster, so you need more oxygen that can cause the pain. And if you have commonly what we're dealing with will be a coronary artery disease, reduced blood flow due to the plug or clogging of your coronary vessels can cause the reduced myocardial oxygen perfusion. You can also have other causes of that lead to angina that not related to coronary artery disease. For example, coronary artery spasm. So this group is not common, but it does identify and can happen in youngsters, especially those with drug chaser, IVDU, morphine or heroin chaser, especially that lead to spasm. Typical question in MCQ would be IVDU user chase for last night just have a heroin chase, suddenly came into emergency with a severe central chest pain. It can present with a similar ECG changes of ischemic changes, or even some significant enough, some people even present with ST elevation. And it can be due to coronary artery spasm because of the heroin or whatever substance that causing spasms. Okay, the diagnosis of it a lot of time cannot be done by just cannot be differentiated by just ECG. You need a CAT lab to go in and to look at the coronary artery blood flow to diagnose this. But the history is very important here, the substance use. Okay. Because anemia, when you have a significant reduction in the hemoglobin or blood in the body, it will cause reduced oxygen carriage capacity. It can cause you chest pain and myocardial or angina as well. Okay. So you need to differentiate what is stable and unstable angina. So unstable angina means that you have the pain even at rest, even without doing anything very significant strenuous. You have the pain, especially when you just walking around a little bit, even at rest, you have pain. That's called unstable angina. Okay, where stable angina means that the pain induced by prolonged strenuous exercise, climbing upstairs, and relief when you are resting. So risk factor for coronary artery disease, you guys need to remember. Most important is just smoking and all those bad habits. Just remember bad habits, alcohol, drug use. Okay, and then the other risk factor will be hypertension, high cholesterol, and obesity. Okay, symptoms of heart attack. I think this is not new to you. So commonly it's still left-sided or upper. Just remember anything happen above the umbilicus can be linked to ischemic heart disease or heart attack. So whenever someone comes in with symptoms of epigastric discomfort, chest heaviness, even shortness of breath, always think of ischemic heart disease first. Okay. Yeah, so it can happen commonly related to the left side. It can even relate to the right side as well. It's not that specific. Okay, so commonly there are other associated symptoms, especially numbness and breathlessness as well. If the heart attack is severe enough, it can cause acute heart failure that can lead to a sudden shortness of breath. The lung will flooded with fluids. You can have sudden heart failure causing leg swelling as well. Okay, so how do we differentiating cardiac pain and non-cardiac pain? Again, this one is repetitive, quite similar than my lectures previously. The pain usually if very cardiac related, patient will feel, especially in ST elevation, they'll feel that they are in doom. The typically they describe will be a severe sharp pain and a very central heaviness. Okay, and happily commonly is still central rated to the left side and it provoked by stress. And the pain usually if the onset is very fast onset, it can last until they come to the hospital or even after hospital. They will not be like, oh, I pain 1 minute, I drink water for a while, the pain resolve. That is against cardiac chest pain, because your ischemia or perfusion to the heart as interrupted. It will not suddenly reperfuse within seconds one, so it doesn't work like that. So if in a real chest pain or ischemic heart pain, the pain will tend to be persistent. It tend to increase in severity very fast, and it also tend to associated with other common symptoms like shortness of breath, especially. Okay, and the pain will not be like only induced with you touching the chest wall with breathing. It doesn't be like, it's not like that. Okay. So in the examination in the heart attack patient, a lot of time their blood pressure can be very high, and because of the pain, they will be in distress. They'll be sweating. They'll be restless. They will not be like just sitting there waiting for you to ask them question. They'll be very restless and discomfort, and some of them may even require morphine for analgesia. Okay, if the heart the ischemic heart attack is bad enough, they will present with failure, whereby they will have high JVP, they will have lung crepitation and also pedal edema. Okay, until here, any questions until the symptoms? Okay.
No, doctor.
Okay. Okay, I hope everyone remember that because ischemic heart attack is still very important. It's sort of like a leak question because you should know about this, and in the exam also we will keep on coming out with the same questions because we expect you to know, and we hope you all know and continue to remember it even after exam, because it will be very useful during your clinical work later on. So how do we investigate someone with chest pain? This is a very extensive list of investigation to work out for heart condition, but you don't need to remember all of this. Just remember a few important one. Okay, of course, the immediate contact with the patient. You want to know the cardiac enzyme, because those are the markers for the cardiac injury, and that's how you differentiate between STEMI, non-STEMI, and also unstable angina. Okay, creatine kinase, LDH, and AST, they are markers of skeletal or muscle injury. They are not so specific, while troponin I, troponin T is more specific for heart muscle. But it does not mean that it's high it's 100% going to be heart attack. It can also elevated in whatever reason or cause of the muscle injury. For example, infection of the heart, pericarditis, myocarditis, all this can increase your marker as well. So ECG, I will talk about it in a while. Chest X-ray, in particularly, you want to look for pulmonary edema, which is a heart failure changes. You want to look for the heart size from the cardiothoracic ratio. Echocardiography usually will not be able to do it during the immediate contact when the patient present because very limited access. A lot of time will be done later on, but it will be very useful for us to have an idea how good is the heart function. We are looking at the ejection fraction, how good is the heart pumping, and is there any other complication from the acute heart attack, including valve rupture or the ventricular wall rupture. So 1 to 4 you need to remember, okay? 5 to 9 is something more advanced. It's good to know, especially you have family members with chest pain. It's good to know how do we progress to work out or re-stratify patient with ischemic heart disease, okay? So what is this 1 to 4 is usually we do in acute patient that come with severe heart attack. So what about exercise stress tests? So some of the patient, they may have a bit of heart condition, they have non-specific chest pain, but they may not able to, we may not able to know whether is there any clot or not, any coronary atherosclerosis or not. So the gold standard, of course, will be coronary angiography. Coronary means coronary vessels. Angio means is arteriography means that a study of the artery. This process is done under fluoroscopy, means that we will use the needle and wire to cannulate our artery, and that wire will bring all the way to the heart vessels, to coronary vessels, and the doctor will inject contrast to see the flow of your coronary vessels. So imagine if you have significant thrombosis or narrowing in the coronary vessels, this can be highlighted very well in fluoroscopy. But not everyone with non-specific chest pain, we're going to do coronary angiography. In short, this is COROS. Short form, we call it COROS. So not everyone we do this angiogram mainly because there's a limited slot, and of course there are significant risks. There's also always risk in doing this procedure, including a sudden dissection, sudden heart attack. So we only offer this in patients that we think are very high risk, that have heart attack, and likely that it's going to benefit the patient. So in those patients that we think that maybe the pain may not be so significant, it may not be really a ischemic heart disease. So those are the time that you use other modality to assess the coronary artery. So one is a exercise stress test, whereby you ask the patient to run on treadmill and see any, indirectly you want to see any changes in the ECG when the patient on running treadmill or not, okay? Dopamine stress test is almost similar. It's reserved for patients that cannot run. You need to able to run on a treadmill for a few, I think 15-20 minutes to stress the heart. But some people cannot run because of knee pain, they cannot walk very well. We would prefer to do dopamine stress test, whereby we inject a chemical called dopamine. This dopamine will increase your heart workload. You stress your heart to pump faster and harder. And if the patient has a coronary perfusion problem, then he will develop changes in the ECG and also changes in the echocardiogram. Okay. And then the CT angiogram is something like the CT scan that you've seen, but just that it focuses particularly in the coronary vessels. So it is to look for the significance of clotting in the coronary vessels. Okay, cardiac MRI is something more sensitive and more specific. It can tell you which area of the heart has reduced perfusion or ischemia. Okay, of course it's very good, but then the very limited access. Okay, and there are options of myocardial perfusion scan as well by using nuclear scanning. Huh? So is all these actually available in Penang? Okay, understand? I know this one is a bit hi-fi, but mainly you need to remember 1 to 4 lah. Okay, 5 to 9 is something that more advanced that can be done to assess the heart disease. Okay. Any question regarding these different types of tests?
No, doctor. It's pretty clear.
Pretty clear. I understand, huh? Because I know some of it you never heard of it before. But if you have family members with heart problem, then you come across all these terms. Huh? Okay, so electrocardiogram, or in short form ECG, is something you will come across again and again. In exam also, typically you will have at least 1 or 2 questions is regarding interpreting ECG. Of course, we only put up something very significant. We will not put in something very subtle for you to see. Okay, so to understand the bit of basic of the ECG, so what are we detecting in the ECG is we are trying to detect the signal from the heart. Okay, so our heart is muscles, but then you need the signals to tell them or to excite them to contract. In the heart, there's a pacemaker, means it's like a generator. Huh? So there's 2 generator in the heart. One is in we call it SA node in the atrium. Another one is your AV node. So the signal actually will start, pacemaker will actually start from your top right of the body, and the pacemaker will send signal to the left side of the body, will be by in this arrow direction. Okay, so what this ECG do is, so you look at how does the lead placement. So it's actually wrapped around the heart. If you look at it, your heart is situated here. So all these leads are actually just sitting in front, on top of the heart, on your hands, actually to pick up the signals coming in from the generator of the heart itself. So what we are actually trying to see here is actually how is the electrical impulse that coming from the heart itself. So that's what we are interpreting. Okay, so this remember this picture. This is what we call sinus rhythm. Okay, so if you see one spike like this is 1 beat. Okay, this is 1 beat. All right. So in the normal heart, you have a rhythm. The normal heart is what we call sinus rhythm. Why do we say sinus rhythm? In the ECG, you can see P. Just remember PQRST. Okay. So we start off with P, and then you have a short Q, RS. The QRS is the largest deflection here. A P, QRS, and the T. So if you see this PQRST in the ECG, this is a sinus rhythm. Okay, just remember this. And in the ischemic heart attack, mainly we are interested in this ST segment. Okay, this I want you to show. Yeah, I want to show you this. Okay, so this is what I'm talking about. This whole thing is ECG single beat. You can see the P wave, Q wave, QRS, and T. So what do I mean by ST elevation? It's the elevation of this segment here. Okay, this is a important concept to know. PQRST means sinus rhythm. For ischemic heart disease, I want you to pay attention in this S and T segment. Okay. So do not need to remember this one. In ECG, there are other information that it can give us a lot of information from ECG alone. It can tell us where is the heart attack occur, which vessels that is clogged, and which area of the heart is having problem, having ischemia or infarct. So the ECG can give us a rough guide. Okay. So I don't expect you to remember the localization. It's just for your information only. Okay, so you can ignore this slide. Good. If you want to know more, this is good. If you want to remember this is important. Um, just remember number A will do. Okay, you need to have ST elevation at least 2 or more leads. Okay, you cannot have if you really have heart attack, it's impossible for you to have only one ST elevation in single lead. So you need to have at least 2 leads in the 12 lead ECG to have ST elevation for STEMI. Okay. Yeah. So this is one of the example of the ECG. Usually an exam also will come out like that. Patient comes in with chest pain. Below is the ECG, and what ECG does this show, or what is the diagnosis? Usually that's how the questions come out. Okay. So first thing when you see an ECG is checking that whether this is a sinus rhythm ECG or not. So I say this is a sinus rhythm. Why? Because there is a P wave, there's a QRS, and there's a T. Okay. Whenever you see this, this is a sinus rhythm. All right. And then you can tell the heart rate by seeing the difference between this is the QR peak, QR and QR. The formula is 300 divided by the number of big boxes here. So this is 1 big box, 2 big box, and 2.5 big box. Or you can just count it to 3 big box. So if let's say there's a 3 big box here, it's just 300 divided by 3, you get 100. So the heart rate about 100. Understand? We'll repeat again in the next ECG, and then maybe you get it. Okay, so most important in heart attack patient, in chest pain patient, I want you to focus at ST segment. Okay, so the normal ST segment will be like this. You can see the ST will be same as the isoelectric baseline. You can see a one straight line like this, right? So this is what we call isoelectric line. So usually your ST segment will be same one. They will be elevated. But what about in V3, V4, V5, and V6? You do not see the ST segment anymore because the whole thing is dragged out. This is the ST segment. So you can see ST elevation in V3, V4, V5, and V6. Okay? Okay. Can see the ST elevation? Okay, maybe we try this one again. Okay, I think this one is more prominent. Okay. So first thing is this an sinus rhythm or not? Let's find someone. Hey, Mark, why don't you answer? Is this a sinus rhythm or not?
Can you point the cursor, doctor? Which one?
Okay, maybe you look at the V5 here.
Okay, the V5.
Line. Okay, can you tell me, is this a sinus rhythm or not? So just now when I say
it's not a sinus rhythm.
Yeah, because you don't see a P, right? There is no if you don't see a PQRST that's very clear defined one. Okay, correct or not? So that you don't see P here and then suddenly QRS and then T, QRST. So this is not a sinus rhythm. This is more complex, but you can definitely tell this is not sinus because there's no PQRST. This is actually a junctional rhythm. Don't need to know about that, but you just need to remember sinus rhythm have to have P, Q, R, S, and T. All right. So imagine this patient comes with chest pain. How about the ST segment? So usually we'll look at every leads now. So how about what do you think about lead 2? What do you see?
For lead 2, it's
Do you see
it's not
ST
an elevation though. Which one?
Yeah. Maybe you tell me which one that you think is elevation. So so let me recap again. So always remember that how do we know it's elevated or depressed? We compare to an isoelectric line. Means that what is the line that you can draw along this thread? So this is the line that we agree that you draw along, you can draw along it, right? So this is the baseline. Can you see my cursor? So the baseline is like that, right now. So let's see this one. So baseline is here. Okay. So this is your Q, this is your R. Going up is R, S. This is your S, this is your T. So what is this?
This one is elevation.
No.
Eh?
If
No.
go up, we call elevation. If go down, we call it
depression.
Yeah, this is ST depression. Okay.
Is it
So
going
you go
down from the isoelectric line? Is it?
Yeah, this is isoelectric. We count from here. So anything below this is depression. Anything above is called elevation. All right. So depression does not tell you infarct, but it tells you that there is a hypoperfusion, there's ischemia. There's a myocardial ischemia going on. Okay. So let's look lead by lead again. Okay. Let's try lead one. So lead one, do you see is it elevation or depression?
Elevation.
No. Try again. This one is a electric line. This is ST segment. This one is down or up?
Down.
Yeah, down. Okay. This is T. This is the ST. This is the ST. This curve, this notch, this is T wave. This is ST. Okay. Try again. Okay. How about this one? This is RS. So about this. Is this up or down?
Up.
Yeah, up. Okay. So this is clear cut. This is up. Okay. So this it doesn't have a P wave here, but anything go down is a Q wave. All right. So you see a Q wave here, and then this ST is also up or down?
Elevated. Up.
Yeah, it's up lah. Okay. So how about lead two? Lead two we mentioned here. So it's up lah. So remember. So there's ST elevation in lead two, lead three, and ABF. This is inferior infarct. We just remember ST elevation is STEMI. Okay. How about this one? Okay. This is the isoelectric line. This is the ST. Is this up? Is it down? Or is this normal?
Up.
Try again. It's a trick. Okay. This is the isoelectric line. Okay. Is this straight or not? Straight, right? It's the same like here, right? Yeah. So this is, there's no elevation, no, because it's static only. It's not up, it's not down, it remains the same. This is normal. Okay. So what about other lead? Let's see lead V2. Okay. This is the isoelectric line. This is the ST segment. This is the ST segment. So what do you see here?
Up.
Up in which lead?
ST. Eh? Oh, lead 2. V2,
yeah, so
V2.
we call it V2. How about V3?
Up.
Up
yeah,
also.
So up, and then here also up lah. So V2, V3, and V4 also up. So there's ST elevation in V2, V3, and V4. Okay. Okay. So if remember what I tell you about the principle of ECG before, is to perceive the signals of the electrical signal from the heart muscles. So when the signals is towards the receptor, the sensory leads on the chest wall, if it towards it, it's going to be a positive deflection. So when you have a heart muscle injury or cell death, the signal will also change because if your heart muscle die already, it couldn't transmit the signal anymore because they die off already. So you perceive changes on the ECG as well. So typical changes is acute ischemia, acute heart attack. You have ST elevation. Later on, the elevation will come down, but you develop Q wave because of the permanent muscle death. Okay, whenever you seeing Q wave means that the injury is not very new. At least it's a few hours already. Okay, so Q wave is a signal of muscle injury or muscle death that already sets in. While ST elevation, there are still chances of the muscle recovery or regain its perfusion if, let's say, it's treated. Okay, so I think this is just to illustrate you how does the progression of the ECG changes in acute MI patient So where is the ST elevation? Anyone can tell where is the ST elevation?
Lead 1.
Okay, it's not so prominent, but more prominent you will see will be
V5.
yeah. So V3 here high also, V4 and V5. Okay, so V3, 4, 5 they are very significant ST elevation. Okay. The lead one may elevated as well, but it's only 2 bits for you to show. So it may not be a true one by looking at just lead one. But from V3 to V5 is very significant as the elevation changes. Okay. And then with time, you will see after 1 hour, you can see the progression. Here, there's no ST elevation. Just now, it's just very mild. Maybe yes, maybe no. But 1 hour later, you see in lead one, the ST elevation significantly going up. Similar as V2 to V4 as well. You can see there's a dynamic increment or changes in the ST elevation up. And then it started to form Q wave. And 3 hours later, the Q wave is setting in already. And at 24 hours, the ST up is coming down and the Q wave is well defined already.
Doctor, just now the Q wave is the one going down, right?
The one going down here. Q wave is not normal. Normal people may have a one single small box going down, but if you see something like this going down so much, so P Q go down that much. This is Q wave. Normal people you shouldn't see so much Q wave unless you have a heart attack. Okay, so this is Q. This is Q. This one, that one that going down. This one going down. If you compare to a QMI at the time, this is still no Q wave one. Look at this. P, there's no Q one. This is just your wave RS. Okay, this QRS is your way here. It does not have a Q wave like this. Okay, can see this? Can appreciate?
Yes, doctor.
Okay. All right. Okay. So I talked about this before. It's just an explanation of the exercise stress test and the myocardial perfusion scan. So we'll reserve this for someone who can run. So how do we know it's positive or not? There's a set of criteria whereby we see on the ECG how significant is the depression. Means it's a directly is telling you that something's wrong with heart perfusion. Okay, well myocardial perfusion scan is by using a nuclear method. This is something more hi-fi where they inject a tracer of nuclear material and you see whether your heart pick up or not. Okay. So this is the exercise stress test. So usually the protocol is they will ask the patient to brisk run or slow run jog on the treadmill, and they will slowly increase the speed and increase the elevation up to a certain degree of the criteria. Is to sort of like to test yourself, test your heart, what is the limit of the heart, okay, and wanted to see at the max limit, do you have heart discomfort on the ECG or not? That is the principle of it. So enough talking about diagnosis and investigation. Lastly is the treatment. In the last 10 minutes, we talk about treatment. So in talking about treatment, we always divide our answer into pharmacological and non-pharmacological. Non-pharmacological means something not medication. So improving or optimizing your risk factor is one of the important aspects. Stop smoking, regular exercise, reduce alcohol, reduce your obesity, reduce your sedimentary lifestyle. It's very common sense. Just remember this few. Pharmacological, our aim is to reduce the chances of the heart to form clot anymore. So we give antiplatelet, we give statin. Okay. All right. So just remember, most important treatment for ischemic heart attack is antiplatelet and statin. Okay. The rest no need first. Just remember these two: antiplatelet and statin. Antiplatelet is to reduce the platelet aggregation, prevent the chances of the formation of clot. Statin is to stabilize the clot itself, the cholesterol clot. Okay, so optimizing your risk factor, non-modifiable. Most of the time, you cannot do anything. The things that you can optimize will be your smoking. Smoking cessation can reduce the risk so much to prevent further worsening of a heart attack. And optimizing your bring down your blood pressure, optimizing other risk factor including high cholesterol and uncontrolled sugar. Okay. So immediate management of heart attack. So you remember the concept again. The heart attack ischemic or STEMI means that there's no blood flow, right? There's a sudden occlusion of your coronary vessels. So how do we manage this? We try to reperfuse the coronary vessels. So the first line will be our aim is to in ST elevation is reperfusion treatment to open back the coronary vessels. So there are two ways. Either you use medication by fibrinolysis, it's a medication to try to dissolve the clot if it's newly formed, or we can use PCI, means percutaneous coronary intervention. It's the same method like your angiogram, where you put a catheter in, you put in the contrast color and to see where is the narrowing, where is the clot, and then you dilate up that segment by doing a balloon angioplasty or by doing a stenting. Okay, other standard medical treatment will be your aspirin, statin, oxygen, and sublingual GTN. Okay. Okay, so remember the concept. Heart attack, STEMI is because of the clog of your coronary vessel. You want to open it back by using medical treatment is fibrinolysis. Mechanical treatment will be your PCI, and other standard treatment will be your aspirin, your antiplatelet, and your statin. Okay, and of course you want to maintain you want to improve the pain, optimize the pain by morphine or GTN. Okay, you do not need to remember the dosage or that. You just remember antiplatelet. One of the example will be aspirin. And to improve the pain, you can give GTN or morphine injection. Okay, this one is also just good to know, no need to remember. And usually invasive treatment is the PCI that I'm talking about. If let's say the patient fail coronary fail balloon or fail stenting, the last resort will be CABG, what we call coronary artery bypass grafting, only in patient that is stable to do. Or when sometimes the clot is too long, that's impossible to put in the stent or unable to open back the coronary vessels, then the bypass surgery will be one of the options. Okay, so how does the catheterization work? So they put in, usually they will puncture the femoral artery, they put in the wire all the way to the heart, and then they once the small wires into the coronary vessels. They find out where is the thrombus formation. They will pass through the guide wire, and then they will dilate up they'll try to sort of like expand the balloon to thin out or unclog the coronary vessels, and followed by a stenting to keep the coronary artery patent. Okay, this bypass surgery, if let's say you have a significant narrowing long segment, cannot do balloon. So bypass means that you graft the vessels from proximal to distal to maintain the perfusion of the distal segment that does not receive blood flow due to the clot. Okay. Prognosis-wise, it depends on the significance, how bad is the heart attack. If you're only single vessels on the right side, it won't cause much problem. If let's say your main supply of the left side of the coronary vessel is blocked, it can cause significant morbidity or mortality due to cardiac arrest, cardiogenic shock, or heart failure. Patient commonly can, in a significant ST elevation, a significant muscle scar injury that can develop arrhythmia, where the heart suddenly beat uncontrolled due to the signal problem. They'll beat, they'll develop ventricular tachycardia, ventricular fibrillation. All this can cause sudden cardiac arrest. Okay. So the things that related to dental practice, of course, will be the chest pain history and medication that patient is taking, especially antiplatelet, because antiplatelet drugs, especially aspirin and clopidogrel, the half-life is about 7 days, 5 to 7 days. So if you plan to have a dental extraction, especially a big tooth, you will need to stop the aspirin at least 5 to 7 days and not just 1 or 2 doses in the morning, because the aspirin effect can last up to 7 days. Same with anticoagulant like warfarin as well. Warfarin half-life is also about 3 to 5 days, and it's causing a lot of bleeding if, let's say, dental extraction is done on someone on warfarin. Okay, I think there are some rules that immediate after acute heart attack, usually dental treatment, if possible, try to delay it, because you do not want accessory risk, especially with sedation or injection of the sedation can give potential harm to the patient as well. Pacemaker wise, if someone on pacemaker because of arrhythmia, if you use something like if you use something with coagulation, with APC or interference signaling on, electrical scalpel, all this can potentially damage the pacemaker because it's very close to the left side of chest wall. So if you really see someone like that, you can actually refer back to the cardio. They can turn off the pacemaker for a while, for a few hours for you to do the procedure and then turn it back on. Okay, I think that is the last slide. Okay, any questions?
Wait, doctor, I think I have a question.
Okay.
Is it in regarding to the, what do you call the graph?
Oh, this one.
The MI at 24 hours, right? On the V5 one, why is it like that?
V5, why is it like that? Let's see. Okay, so if you compare to here, actually it's trying to come down. If you compare to here, this is the V5 at 1 hour. You can see this is a sinus rhythm log, PQ, RS, and the ST up is still very high at 1 hour. And then the 3 hours start to come down already. And then at the 24 hours, it's still high, but then it's actually coming down almost back to baseline already. So this is just a normal progression of the ECG of it. So nothing specific here, but the ST elevation is slowly coming down back to where it was. Yeah.
Just now, you said that for Q waves,
correct.
It's present due to myocardial injury, right?
Infarction, correct.
Infection, right? Will it still be present? Like
the Q wave, it depends on which angle you are looking at it. So, and also how significant is the injury. So a lot of time, especially the anterior leads one, the V1 to E4, you will see the Q wave because the heart muscle is just directly in front of the leads. So you can identify the Q wave easily. Some of the leads like V5 and V6, they are at a smaller margin. So you may not able to pick up the Q wave that much. But you were able to see in other leads like this one. If you develop a heart attack, you have this one. You have the Q wave here. The Q wave is here. Okay, because something you may not you may have the Q wave, but then your signal does not perceive it like that. This is a bit more complicated because of the signal of the heart. So and also the angle of your lead placement make it you difficult to see Q wave in V5 and V6. Okay, because of QRS signaling overlapping with your Q wave at V5 and V6. So your Q wave may not be so prominent in V5 and V6, although there's already muscle injury. Okay, just remember that it's because of the how the ECG orientation. So Q wave in V5 and V6 will not be so prominent to see, but in V2 and V4 it will be very prominent, and also in other leads like lead 2, 3 AVF, you can see quite prominent Q wave. Let's say there is a muscle death.
All right, doctor. I think that should
Okay.
be all.
Yeah. So don't worry about the ECG. You have more ECG to see in the subsequent lectures, because there will be other rhythm that I wanted you to know. So so try to remember. Visually, ECG is more like a pattern recognition. So there's specific pattern that you need to remember, especially like this, the ST elevation. So the more variant you see, then you know one look, you know, oh, this is Q wave, or this is ST elevation. Okay, when you initially exposed to this, you may not able to know because you does not familiar what is the segment yet. The more you see, the more you will know. You'll be exposed to more ECG in the subsequent lectures. Okay.
All right, doctor.
All right. Any more questions? If no questions, then we will end here.
All right, doctor. We just take picture lah.
Okay.